Okay, so I thank the organisers for the kind invitation to talk in the symposium on challenging cases. So we're switching back to the back of the cornea now. We've had a lot of talks on ocular surface, so I'm going to talk about how to deal with posterior stromal scarring. This is my disclosures. Can you make the slides? Some of my slides are the edge of the slide is missing. That's great. Okay, so all of you will be aware, obviously there's been a changing phase of corneal transplantation over the last decade and a half, and endothelial keratoplasty now is overwhelmingly becoming the most common surgical procedure that we do. But the downside of basically EK, whether you do DSEK or DMEK, is of course it doesn't replace the stroma. And many patients present with advanced corneal stromal scarring, as we can see in this example over here, especially in Asia, where they may actually present late to the clinician to undergo some sort of therapy itself. And of course, when you have severe stromal edema, it can be very poor visibility for doing any form of EK surgery itself. Some patients may present with more severe scarring that goes all the way down to the posterior part of the stroma, so then you may think that we need to basically do a full thickness graft as well. And of course, in children, when there's issues with basically posturing postoperatively, that may require multiple GAs. If you're doing basically having to get rebubbles for your DMEX, then of course this can be an issue when we're thinking about planning for surgical procedures in the future as well. So when we think about posterior stromal scarring in general, you can classify this. I mean, this is just something that I just came up with just when I was talking about preparing this talk. Primary or basically secondary. Primary scarring you typically see in cases of Fuchs. We see this quite a lot more in Asia than I used to see in the UK, where behind the guttae you've got a fibrillar layer matrix down of extracellular matrix on Descemet's membrane itself, and that's required. You need to remove the Descemet's membrane in such conditions itself to try to improve the visual acuity, and the visual disturbance is not occurring from the guttae alone. Or you can basically have secondary cases of corneal edema. This can be related to basically severe corneal edema, post-infectious keratitis. Typically, I see this with herpes simplex, or it can be basically iatrogenic, either from basically post-surgical trauma, or it can basically be glaucoma device-related. And these are the three I'm going to talk about and how we're going to basically manage these in a little bit more detail. AIOS2025, I think, is really valuable to basically give you an idea of basically how to manage these cases. And looking at basically the folds on the posterior stroma with AIOS2025 will give you an idea of the chronicity of the scarring itself and also the signal. And that will then basically determine what kind of surgical procedure that I will do in each of these cases. So in the one above with severe corneal edema, corneal thickness may be around about 1,000. But if you look at the folds in general over here itself, you can see that the signal above and below the fold actually is quite similar. So it tells you that basically this is not a chronic scar that you can see basically present. So it's possible to remove this. Once you remove the Descemet's membrane, the scarring and the fold should basically come out. While in this case below over here, related to herpes simplex keratitis, these are fixed folds, and you can see the change in the signal and the thickness of the fold itself actually is all the way up into the base of the lamellar graft itself. So in this situation, just doing a standard DMEK is basically not going to help you, and I'll show you basically how we deal with this. And in this situation over here, where you have basically a tube, this tube was done in the States. They put it in the inferior fornix for some reason, and it was basically causing a lot of fibrotic damage at the inferior part of this cornea. While here again, if you just do DMEK alone, it's not going to basically be able to get rid of the scar, and I call this DMEK plus, and I'll show you basically how we basically handle this case. So let's look at that case with the tube. This is a 54-year-old Arabic guy. He basically had bilateral POAG. He had his tube done in the United States in Bascom Palmer in 2011. Left eye had basically quite a difficult course following trabeculectomy. His pressure was well controlled on both eyes. Visual acuity was 618, but he had this chronic inflammation inferiorly. This is basically where his tube is over here itself, and he was seen by the glaucoma service, and then he was sent to me to have a look about what to do with his cornea. You can see over here in this area, this is the inferior tube, and you can see here on the slit beam over here where he's got very localized edema. Even the tube is actually not touching the cornea itself. You can see the anterior placement of the tube is very close to the transition zone, and of course basically you can see that he's already got basically early decompensation around this area of where the tube is basically placed. This is what his AIOS2025 basically looked like. So you can see the inferior improved thickening in the inferior part of the area, but the normal epithelial basically thickness. So we followed him up over time. So as he basically came back every sort of 3 months, you can see that the edema is slowly basically creeping up. Now it's basically midway, and he's getting basically epithelial edema on the surface. Now you can see his central basically corneal scarring has got to basically 729, and then he basically got worse up to basically 749, and now you can see he's got complete almost corneal decompensation. Maybe this area at the top over here is not decompensated, and this is what his eye basically looked like. It changed from that situation literally over a 6-month time period to this situation over here itself. And now it's a little bit more easier to see those fixed folds that you can see in this area over here itself. And this has occurred because he's got basically some inflammation above Descemet's membrane. So if we look at basically the OCTs now here in a little bit more detail, this is basically the relevant OCT from this scan, and this is basically what his OCT basically looked like following much, much more severe edema. And what you can see is if you look at the area of where he's got this basically posterior fold, this has become much, much more mature, and there's a change in the signal on the AIOS-OCT. So tell you this scarring has become basically much, much thicker. And this is basically what he looked like before I basically took him to surgery. So his whole cornea now is thickened to about 1,000 microns, and you can see this elevated mass of scarring over here above basically Descemet's membrane. So what that means is that basically it's interfering with around the level of Jewess layer. So if you just basically do a DMEC, you're still going to leave the scarring basically back there in the same situation. So this is basically how we deal with this in this situation. So obviously remove the epithelium to basically try to get a better view. To show you the fact that it's just if you remove the Descemet's membrane is not going to help, I'll show you what happens after we strip off the Descemate. So the first thing I did was basically trim the tube back, because I thought when I do a graft over here or do a DMEC, I don't want it to basically be anywhere near touching the tube. Okay, and one of the other options is that often I get the glaucoma people to actually replace the tube slightly more posterior, so it's sitting basically on the iris plane. So once we take the tube out, now we'll basically do a standard Descemet stripping, and you'll see what happens when we get to this area over here. You see the scar is still there. So that's why Descemet stripping alone is not going to help you basically in this situation, okay? So what you need to do is you need to remove the Descemet to get access to that basically scarred area. And then once you've got access to the scarred area, what I will do is I'll go with a pair of forceps, and what you want to do is a localized basically peel and get the edge of that scarred fibrotic area. You can see they've got an edge there with a forceps, so using a blunt tip forceps, and you gently peel away the stroma in this area. And this requires multiple goes to basically do this. If you don't do this, when you do the DMEC, it's not going to basically stick in this area. What you can see is that once the stroma turns into this uniform whitish basically color, you basically remove most of the scarring. So this is basically what they look like. This is post-op. You can see basically on this side over here. So the DMEC is basically start. This is early post-op. This is the same OCT now in that area of where you basically saw the scarring. And then this is basically what it looks at high basically power view in this area where you can see the scarring is basically completely gone in this area. So doing a localized fibrotic stripping of that area of thickened tissue will allow you to basically clear this area. But you shouldn't just put a DMEC alone there itself, because the scarring will basically remain, and also you can increase your risk of basically getting a detachment. Okay, so what about that fixed fold? So this is that lady actually one step slightly earlier. She's a 72-year-old Chinese lady, previous history of herpes simplex keratitis. She's pseudophakic in this eye. The herpes simplex lipid basically got worse. You can see this basically from the clinical photographs. The vision had dropped down basically to count fingers on this side. Again, if you look at the OCT over here, you can see this is the lipid deposition in the basically stroma. And if you look very carefully over here at slightly more higher magnification, you can see these little folds over here in basically the posterior stroma itself. Now, this has come from herpes simplex infection. I've seen this quite a few times, and often this is basically a chronic inflammatory process giving this, and you're going to get fixed folds basically over here itself. So what I did for her was I did a DOLC basically first of all. So this was done with a manual basically surgical technique. I dissected down to within 50 microns of Descemet's membrane. So you can see this basically over here. Visual acuity improved, but not fantastic. And you can see now the fixed folds over here. It's not possible to basically remove it because they're so stuck down onto basically Descemet's membrane. If you try to remove them, you're basically going to rip. So this is basically what she looked like. This is basically the OCT, and you can see the full thickness folds over here, and again, in slightly more higher powerful magnification, you can see Descemet's membrane over here, and these folds go well beyond that, up into basically the base of the DOLC stroma itself. So again, if you just strip away Descemet's membrane over here, you're not going to basically be able to get rid of these folds over here. So in this situation, you know, there's several options from there itself. Of course, you could convert her to do a PK, but obviously it's a high-risk case with herpes simplex and in one area of vascularization, so we wanted to basically do something else. So in this situation, what we do is do the surgery basically that we call FAD, so intraoperative OCT-guided femto-assisted DMEC. So basically we use the OCT on the Zima femtosecond laser. And what I'm going to do is I'm going to cut from the inside of the cornea itself right up into basically the DOLC tissue. So now we're using the intraoperative OCT, so I can see exactly where the margins are and how high the vertical trephination needs to be. The advantage is because this is done with a liquid applanator, there's no distortion on the surface of the cornea itself. So once you've gone all the way around, it's done in 30-degree segments. You basically fire the laser. So the laser is now firing from the anterior chamber vertically upwards into basically the DOLC tissue. You can see the bubbles there around that's basically created by the femtosecond laser. Then using a Sinskey hook, I gently tease away the edge of basically the stromal tissue. I'm gently dissecting it. Now, where the sutures are, of course, it'll be a little bit more tighter with the cutting from the laser itself, but you can see you've nicely basically removed that tissue itself. You can see on the surface, that's the scar. So you can see the scarred area basically over there, so now it's removed. And now what I do is I replace that area then with a DMEC. Now with the DMEC, a little bit more challenging over here because you've got an edge that you need to put your DMEC tissue within that area itself. And the advantage of doing a DMEC in this situation is that you're basically getting rid of the interface, so the quality of vision should be slightly superior. So we do an endo-in technique, so we're holding onto the graft. So once the graft is in position, you will then basically tamponade this with gas like we do basically with normal surgery. So there we go, it's just tamponade with gas, and then the rest of the graft is basically opened up. So this is what she basically looked like. She had a small detachment at day one. She was actually one of the first cases that I basically did. I rebulbed to her with SF6 gas, and then she got an excellent visual acuity outcome. Her best visual acuity is 6.9 with a basically good cell count. Now she's about 4 or 5 years down the line as well. So in conclusion, with increasing trend to lamellar surgery, sometimes it's difficult to ascertain endothelial damage, especially if the scar is very, very posterior itself. The clue basically with the cause of the scarring, try to think of the cause. If it's primary cause, you're most likely going to get away with a standard DMEC. If it's secondary cause, you may have to do an alternative technique. The duration of the edema and the scarring basically help you guide. The OCT, I think, is really invaluable to really look at the depth of the basically the chronic scar. If you see a signal change on the OCT, it's telling you that basically you're going to have to do something else. Just doing a DMEC alone will not help in this situation. I still think it's best to do EK surgery, but the best surgical treatment may be on standard DMEC, either a combination of what we call DMEC plus or basically IFAD or intraoperative OCT guided femto-assisted DMEC. Thank you for your attention.
Thank you, Jod. Pretty good timing. Let's open the floor for some questions before we close. Vidavon?
Thank you very much. That is very beautiful surgery. I would like to ask, what is the when you see the fold in the endothelial? So
yeah.
At what point that you consider this as a fixed fold that you have to remove before the DMEC surgery?
So I think that if you do the OCT and then really look at the OCT, but typically look as to see whether there's a change in the OCT signal. If it becomes slightly whiter, okay, it's going to tell you it's going to be a chronic fold, okay, because it's telling you it's a chronicity basically there itself, and fixed folds in the matrix will basically be chronic. It will definitely be chronic. With herpes, I've seen this actually quite a lot, actually, and actually before we start, I mean, I've done about maybe 15 of these techniques now with the laser. Before we did this, actually, I wasn't sure what to do. I used to just do a dog and just used to leave the vision around about that level, and now we started doing this with a laser. I do all of these I do a dog, first of all, very deep, and then I basically do a laser afterwards. But if you do the OCT, I think is the OCT history to give you an idea. If it's just non-surgical, with, like say with Fuchs, for example, primary Fuchs, when you see that ACM matrix, almost 100% you can strip that off and you'll be absolutely fine with the standard DMEC. But if it's post-surgical and you see it's actually fixed, you definitely need to use that. And using, you can use forceps or you can use, sometimes you can use cyclodialysis spatula just to get that plane. And once you get that plane, you can peel that fibrotic scar off. It's quite easy to basically do.
I ask a little more about using the femtos second laser. Have you done some of the DSEC by removing the posterior stroma of the recipient as well before putting all the...
So the problem with that is that currently with the liquid applanator that you have, you can only cut vertically. You can't cut horizontally. So that's the issue. So I tried to do one, but the problem is that to do a horizontal cut, you need to use the flat applanator. So we do it for DOLC when we do big bubble, but we don't do it for EK surgery because the problem is that when you're basically applanating down, you don't get a very even plane in the posterior stroma. Now, there is a new upgrade coming, and we're working with Zima to be able to cut a horizontal line with the liquid applanator. So when that comes available, then that might be possible. Yeah.